Welcome to video 15 of the Safe Recovery Training Program, focused on setting and reviewing goals. I'm Terry Haines. The objective of this video is to learn how to set and review goals in the context of the Safe Recovery Program. Safe Recovery Program, as we've discussed in previous videos, has an information gathering and an information provision and joint problem solving phase. We're now at the end of that joint problem solving phase where we're setting goals and reviewing those goals. When identifying strategies and goals for the patient, again, I want to emphasize that these can be initiated by the patient or yourself, but you must try to use a collaborative approach and avoid the didactic way of just telling patients you should do this. You are facilitating the patient to set their own goals as much as possible. You want to equip them and enable them to be the center focal point of the safety effort while they are in hospital. However, we do have to consider whether they want to perform the strategy or the goal that's been identified. In a pure motivational interviewing approach, you might ask a patient to rate their motivation out of 10, 10 being completely motivated, 0 being not motivated at all. If they give you a score of 1, 2, 3, 6, then get them to reflect on the positive side of this. You would say something like, okay, so you're motivated 1 out of 10. Tell me, why did you rate it so highly? So you're getting the patient to restate the reasons behind why they might want to do the particular behavior. This is a form of encouraging self-talk in the patient, which is a potential motivating and behavior changing approach. In providing the Safe Recovery Program, you can use this approach, but you don't necessarily have to be so overt. Perhaps you can just ask, so why is it so important to you that you perform this particular strategy? And again, understanding the reasoning the patients put forward is very useful both at the time and also for future review appointments when you might want to discuss with patients why they were or were not able to perform the activity that they set the goal around. When trying to understand why patients want to perform a particular strategy, use the point of leverage. We want the patient to be able to draw a link between the point of leverage and the strategy that's being proposed. So if you can get your patients to give the following sort of statement: if I ask for help, I'll be able to get around the bed with a lower risk of falling, so I'll be less likely to break a bone and to spend longer in hospital before I can get home to do my own thing. So if you can get your patient to say something like that, where they've identified the link between the leverage point with the behavior goal and with reducing the risk of falls, then you can have a quiet little celebration in your own mind and move on to the next goal. That's wonderful if you can get the patient to express something along those lines. Again, getting the patient to express it out loud is also another form of behavior change strategy. With identifying strategies and goals, the Do It For Me approach is an approach that I've mentioned a number of times in the previous videos, but I haven't explained just yet what it is exactly. This is for situations where some patients are there who reject their own risk of falls, or there are some patients who don't believe a particular strategy will help them to reduce their risk of falls. Many of these patients, however, are very altruistic and want to help people and want to be good patients. The Do It For Me approach may work for these patients, particularly in the short term. But for it to work, essentially, you have to make sure that they believe you are on their side and that you have built a rapport with them. They have to believe that you will experience worry, stress, or anxiety on their behalf if they don't reach the goal. This creates a cost of not doing the intervention or not achieving the behavior change activity that's the focus of the goal. So basically you are saying to the patient, okay, I accept that you don't think you're at risk of falling over. I accept that you don't think that if you ask for help to go to the toilet that will reduce your risk of falling over. However, could I ask you just do it for me? It would make me worry less about you. It'll make me stress less and be less anxious on your behalf if you could do that for me. So if you can create that perception in the patient's mind, then if we think about framework 2, then that creates a perceived cost to others from undertaking the strategy, which actually lightens the load of the cost of undertaking the strategy overall. In fact, is probably a form of benefit in many ways. With recording the goals, you want to make sure that the goals are recorded both by the patient and yourself in a way that is specific, measurable, attainable, realistic, and timely. These are SMART goals, and this is something that you've most likely encountered in many other courses and educational programs. But the principles for using SMART goals holds true for the Safe Recovery program also. So an example of a nice SMART goal here would be, I will ask for help from a nurse when I need to go to the toilet every time I need to go for the next 2 days. And I've again emphasized the short-term nature of the goals that we're trying to set. We're only trying to bargain for behavior change for very short periods of time. If we put too long a periods of time attached to these goals, then the ability of the patient, or the perception of the patient, that they will be able to achieve these goals and meet these goals will be reduced, and their likelihood of trying to achieve the goals will accordingly reduce. So if they have a short time frame, they will have a greater possibility of thinking that they will be able to achieve the goal, and therefore be more likely to attempt it. With the goals, write them down. Ideally, get the patient to write them down on some paper that they can keep. However, often you'll need to do this, as many older adults have difficulty with writing, and some find it very embarrassing to show other people their handwriting. However, it's still important to get it written and a copy given to the patient, because this will promote accountability. Give them the Arnold Schwarzenegger line, tell them I'll be back to check those goals out. And if the time frame is 2 days, then tell them you'll be back in 2 days. Use the workbook or provide them with your own template, and leave the goals with the patient. Now, half of your patients will take the piece of paper, fold it up, and put it in their top drawer so nobody else can see it. That's okay. You know it's there, and the patient knows that you know it's there, and that you'll be back to check up on them in 2 days' time. Now, once we've set the goals, your next job is to review the goals. Reviewing the goals is essential to promote accountability, and this needs to be planned at the end of the first session. So tell the patient, yes, I'll be back in 2 or 3 or 4 days, however long the time period might be, to check up on you, to find out how you are, and also to check how you've gone with meeting the goals that you've set. When you conduct a review assessment, establish if the goals that have been set have been attained. This may require some probing. However, do congratulate the patient even for a very small success or a partial success. Help them to feel the encouragement, a pat on the back at an early stage. Also establish if there have been any falls, as we did when we went through self-learning activity number 3. Now, the first review should take place between 1 and 3 days after the first set of goals have been set. Try to avoid going any longer than this. Again, too long a period may diminish the sense of accountability, and too long a period may make it harder for the patient to achieve their goals. So it's good to have the patient have a win at their first review. Don't set the bar too high. When you commence the review, establish if the patient has been well since the last visit. The patient may have important news or an experience that they want to discuss. So again, let them take the reins for a period of time and lead the conversation. Establish if the patient has fallen, and if they have, follow the same procedure as for conducting a falls history. Discuss also how the goals that were set relate to the fall that took place. So if one of your goals that was set was to ask for help, every time you go to the toilet and the patient fell while trying to go to the toilet, establish if they had asked for help with trying to perform that activity. During the review, establish that the goals have been achieved. If they have and no fall occurred, then draw a direct link for the patient between the goal achievement and not having a fall. So say something along the lines of, okay, so your goal was to ask for help with going to the toilet every time you went, and you achieved that over the last 3 days, and you didn't have a fall as a result. That's great. However, the Safe Recovery Program does not prevent every fall. The reductions that we've seen in our research have been between 30 and 50% for different populations and patient groups. So if they have achieved their goal, there are sometimes going to be occasions where a fall has still occurred. So you may need to revise the goals that were set and recognize that we're not going to be able to stop every single fall that might take place on a hospital ward. If the goals have not been attained, don't blame the patient. Instead, try and find out why and be as constructive as possible. Help the patient to problem solve issues that have arisen. Again, try not to be didactic here, yet facilitate the patient down the path of identifying constructive ways to achieve the goals that have been set. Again, you may need to set an alternate set of goals. You may need also to revisit the fall that the patient perceives is most likely to occur. Now this is particularly important as the patient's condition changes. The fall that the patient thinks they might be most likely to encounter might change as their mobility improves during their rehabilitation and recovery. And this is important for them to reset and recalibrate the goals they set, and that eventually what you want the patient to be able to do is to be independent with setting these goals, so that in future review appointments they don't need you to lead this discussion. Then instead they can tell you what goals they've set for themselves for the next couple of days independently. That's the ideal scenario. Now, subsequent reviews after the first review can become less formal. My general rule of thumb is for the first review you sit down with the patient, but for the second review you're standing in their doorway and don't take a seat. Really, you're just popping in to check up on the patient and find out if there are issues that have arisen, find out if any falls have occurred, and find out if the goals are still being met. Frequent but short bouts of contact can still facilitate adherence quite nicely. And when you're on a particular ward, providing the Safe Recovery Program, you want to be able to just touch base very quickly with a number of patients that you may have been seeing in recent weeks.